Hello students, I am Dr. Shimona Garg, your dermatology faculty at Manipal Medes, and today I am going to present to you Dermatology NEET PG 2024 recall. Overall, you got around 14 to 15 questions in dermatology. All the questions were covered in our Manipal Medes app. So these questions, they were overlapped from microbiology, gynecology, forensic medicine and pathology. The questions were simple, and even if you don't know the answer, you can easily reach up to the right answer by ruling out the other options. Okay, so the first question is, a patient presented with alopecia as shown in the picture below and along, he had grey patches over the trunk and moist lesions over the groin. What is your diagnosis? HPV, LGV, molluscum contagiosum or syphilis? So the key words in the question are alopecia. As you can see in the picture also, there is presence of multiple non-scarring alopecia, multiple non-scarring patches of hair loss. The patient had grey patches over the trunk and moist lesions over the groin. So this picture is consistent with secondary syphilis. So the answer is D. So this is moth-eaten alopecia. The other features are presence of maculopapular rash over the body. The rash is non-pruritic and non-vesicular. The lesions can be present over palms and soles also. So the moist lesions in the groin and anal area, these are condyloma lata. The most infectious lesions, these lesions are flat-topped. And then snail track ulcers in oral cavity. Next question, identify and label the structures. Okay, so what you can see in the picture is, this is skin, right? And this is hair. This is eccrine sweat gland. This one is erector pili muscle. And then this is sebaceous gland. Just above this coiled structure is apocrine sweat gland. So this is the orientation of the glands within the body. So you can see that the eccrine sweat gland is opening directly onto the skin. So it excretes via exocytosis. Whereas both the apocrine and the sebaceous glands, they are opening into the hair follicle, right? So the apocrine gland, it excretes via pinching of a part of the gland pinches off, whereas sebaceous gland, the whole cell disintegrates, holocrine secretion. So this erector pili muscle, this is the muscle, it divides the hair into two parts, upper segment and lower segment. And the sebaceous gland, this is the sebaceous gland, it divides it into infundibulum and isthmus. So this is infundibulum, this is isthmus, this is erector pili muscle. Here we have the bulge containing the stem cells. This is the stem part, this is the bulb part containing dermal papilla. The next question is, the logo of National Leprosy Eradication Program is. So this is how the logo looks like. You can see that there is presence of lotus, which indicates beauty and purity. Then this is the sun part, which means hope. And this part is partially affected thumb, which means that leprosy can be cured and the patient can be a useful member of the society. The next question, in dermatitis herpetiformis, antibody is directed against which antigen? So very important topic, dermatitis herpetiformis. So the antibody is tissue transglutaminase type 3. The answer is D, tissue transglutaminase type 3. Anti-nuclear antibody you see in connective tissue disorders. BP120 is seen in linear IgA disease. And keratin 5 epidermolysis bullosa simplex. The next question, a patient presents with vesicular skin lesions and buccal mucosal lesions. His direct immunofluorescence is shown below. What is the diagnosis? Okay, so the key words in the question are there is presence of vesicular skin lesions and buccal mucosal erosions or lesions. In DIF, you can see a typical fish net pattern, also known as chicken wire pattern. So even if in the question there is nothing mentioned about the type of lesions, just by seeing the DIF you can tell that the answer is Pemphigus vulgaris because of the characteristic DIF appearance fish net pattern. Deposition is intradermal and because of acantholysis the deposition is in a fish net pattern. The next question. A patient presented with reddish orange hue with keratotic follicular papules as shown in the picture below. What is your diagnosis? Eczema, Pityriasis rosea, Pityriasis rubra pilaris or psoriasis vulgaris? So the key words in the question are presence of reddish orange hue, keratotic follicular papules. Even in the picture you can see that there is presence of follicular papules. There is presence of erythema and also there is spearing. You can see spearing. It's not uniform. So this is a typical case of Pityriasis rubra pilaris. In eczema, the patients they complain of dryness. There is presence of scales. Then in Pityriasis rosea, the patients they have typical herald patch with colorate of scale and secondary eruptions over the back in a Christmas tree pattern. In psoriasis vulgaris, there is presence of characteristic loosely adherent silvery white scales. So Pityriasis rubra pilaris. Pityriasis means there is scaling. The scaling is fine, furfuraceous, briny. Rubra means red. So it is erythematous, red-orange hue. Then pilaris, which means follicular. So there is presence of acuminate, pointed follicular papules with perifollicular erythema, giving a nutmeg crater appearance as you can see in the picture. Also from P you can remember there is presence of palmoplantar keratoderma. Also characteristic spearing, islands of spearing. And these patients they can land up in erythroderma also. Pityriasis rubra pilaris. The next question, a patient with multiple sexual partners presented with painful grouped vesicles over genitalia as shown in the picture below. What is your diagnosis? So the key words here are multiple sexual partners presented with painful grouped vesicles over genitalia. As you can see in the picture also, there is presence of multiple vesicles on an erythematous base. These vesicles, they are grouped, right? So, painful. So, of course, if the patient has multiple sexual partners, it gives you an idea that the patient is having a STD, right? Painful lesions, they are present in herpes and chancroid, right? So grouped vesicles, all of the other STDs, the patients will be having ulcers, whereas in herpes, the patient has grouped vesicles which rupture to form erosions. So grouped vesicles, characteristic appearance of herpes genitalis. So this is a case of herpes genitalis. So the next question is, Nugent score is used for which of the following diseases? Bacterial vaginosis, candidiasis, chlamydia or trichomoniasis. So Nugent score is used to scale the presence of vaginal microflora, especially lactobacilli. Okay, so normally the score is 0 to 3 because of presence of lactobacilli. But in bacterial vaginosis, there is bacterial imbalance. So what happens is there is decrease in lactobacilli and there is increase in Gardnerella, anaerobes, mycoplasma, right? So in that cases, Nugent score, it increases. So 0 to 3 indicates there is presence of lactobacilli, right? So in bacterial vaginosis, the score will increase, indicating the presence of other organisms. So Nugent score is used for bacterial vaginosis. The next question, a male presented with urethral discharge, gram stain shows intracellular diplococci as shown below in the picture. What is the treatment of choice? Azithromycin, ceftriaxone, doxycycline or penicillin? So the keywords here are the patient has urethral discharge and the gram stain shows intracellular diplococci. As you can see in the gram stain also, there is presence of gram negative diplococci within the cells, right? So indicating that the patient has gonorrhea, gonococcal urethral discharge. So the incubation period of gonococcal urethral discharge is around 2 to 5 days. These patients, they have profuse purulent discharge and they have intense burning sensation. The patients complain of fever and constitutional symptoms. So the treatment of choice is injection ceftriaxone, option B. Injection ceftriaxone intramuscularly, single doses given. So earlier we used to give cefixime and azithromycin in these patients, but gonorrhea is getting resistant to most of the drugs. So now the treatment of choice is injection ceftriaxone. So we can give doxycycline along if we can't reach up to the diagnosis, if our diagnosis is urethral discharge. So we don't know that the patient has which kind of urethral discharge, but here we know that it is gonococcal, so the treatment is ceftriaxone. If we don't know, then we'll be giving the patient ceftriaxone as well as doxycycline along with it for other non-gonococcal urethral discharges. The next question is, which is least likely organism responsible for the below condition? So the options are epidermophyton, microsporum and trichophyton. And in the picture what you can see is presence of grey patch Tinea capitis. As you can see over here, there is presence of grey patch. Grey patch is non-scarring Tinea capitis caused mostly by microsporum species. So least likely, trichophyton infects all the three, skin, hair and nail. Microsporum, M does not infect N, which means microsporum species are not infecting the nails, and epidermophyton, E, does not infect H, which means epidermophyton does not infect hair. So here the answer will be A, least likely, right? So the next question is, a child presented with night blindness and Bitot spots, cutaneous finding is given below. What is your diagnosis? So the keywords here are night blindness in a child and presence of Bitot spots. Even if you don't see the picture over here, you can very easily tell that we are talking about vitamin A deficiency about here, right? And in the picture you can see over the elbows, the patient is having keratotic spikes, follicular plugging, right? Indicative of phrinoderma. So the patient has vitamin A deficiency and the cutaneous manifestation is phrinoderma. The next question, a female from Bihar presented with pigmentation, fever and hepatosplenomegaly. Which vector transmits the disease? So the keywords in the question are Bihar, pigmentation, fever and hepatosplenomegaly. Indicative of leishmaniasis, visceral leishmaniasis caused by sandfly Phlebotomus argentips. So the right answer is B, Phlebotomus. Next question, a patient has sinus tracts on foot with filamentous organisms on smear. What is the likely diagnosis? So the keywords in the question are sinus tracts on foot and filamentous organisms on smear. So here we are talking about Mycetoma, in which the patient complains of triad of swelling, discharging sinuses, having grains. So filamentous bacteria are basically Nocardia, it can be Actinomadura or it can be Streptomyces, responsible for white grains. Whereas even fungus can cause mycetoma caused by Madurella species, and in that the patient has black grains. The next question is, patient presented with hyperpigmentation and measline. Which of the following poisoning patient has an overlap with forensic medicine? Okay. So here the keywords are hyperpigmentation and measline. So hyperpigmentation and measline. Measline, it is arsenic poisoning. So here the answer is arsenic. So what you see in arsenic poisoning from your chapter of disorders of hyperpigmentation, you should remember arsenic. So there is raindrop appearance. There is presence of hyperpigmentation with few hypopigmented macules, as you can see over here. Diffuse hyperpigmentation with hypopigmented macules, and here you can see measline, transverse white band, single transverse white band, seen in arsenic poisoning, lithium poisoning, and in cases of renal failure. Whereas Merck's line, in which there is presence of multiple transverse bands, you can see that in chronic hypoalbuminemia. The next question, what is the diagnosis? So this was the histopathology picture given to you. What you can see in the picture is that there is, so only this much is the epidermis. So there is atrophy of the epidermis, and here you can see a box shaped dermis with presence of sclerosis, absence of adnexal structures, right? So this is consistent with morphia. In lichen planus, you have very characteristic histopathology. There is hyperkeratosis in stratum corneum. In granular layer, there is hypergranulosis. And then what you can see is basal cell degeneration, which is the pathognomonic sign of histopathology of lichen planus. Also, the rete they are pointed, giving it a sawtooth appearance. Whereas in lichenitis, what you see is presence of intense lymphocytic infiltrate in the dermis, and it gives a claw clutching a ball appearance. So this is a characteristic case of morphia. So even if you don't know what it is, you can always rule out the other options. I don't know the option D, but yeah, you can rule out lichen planus and lichenitis, and the answer becomes morphia. So that's all from my side. So lots of overlap this time, and the questions were relatively simpler only. All the best for your result. Thank you.